Hello everyone, I am Dr. Pawan Kumar Vecham. I work as a consultant in the Department of Critical Care Medicine at Apollo Hospitals, Chennai. As a part of antibiotic stewardship program, I am talking about central line related bloodstream infection. CLABSI is defined as laboratory confirmed bloodstream infection not related to an infection at another site that develops within 48 hours of central line placement. These are the images of commonly used central lines in an ICU. The first being the triple lumen central venous catheter. The second is the hemodialysis catheter, and third is invasive arterial line. There are several indications for these devices in an ICU setup. Administration of multiple medications, short-term or long-term hemodialysis, massive transmission of blood products, perioperative periods, especially during transplant surgeries or major surgeries, use of chemotherapy agents, patients with difficult venous line access, and during hemodynamic monitoring. So, in etiology, bacterial infections are far more common than the fungal infection. Among the bacteria, so the gram-positive organisms like coagulase negative staphylococci, enterococci, and staphylococcus are commoner. Among the gram-negative bacteria, Klebsiella, Enterobacter, Pseudomonas, E. coli, and Acinetobacter are more common. In the fungal infection, Candidal species are more common cause of fungal infections. In the history and physical examination, so the clinical manifestations of CLABSI vary depending on the severity of illnesses. Fever and chills are the most common manifestations, but they are masked in certain individuals, especially the immunocompromised individuals or people with extremes of ages. They'll have atypical presentations, and they being like altered mental status, hypotension, lethargy, and fatigue. Exit site examination becomes a very important aspect in CLABSI. You have to look for signs of inflammation like redness, pain, discharge. Especially in the tunnel infections, you have to feel for tenderness in these patients. For long term catheters, difficulty in drawing blood or poor flow are considered risk factors and manifestations of CLABSI. Coming to the evaluation, there are two terminologies. First is catheter related bloodstream infection, which is preferred by IDSA. The definite diagnosis of CRBSA requires one of the following: isolation of same pathogen from a quantitative blood culture drawn through a central line and from a peripheral line with a single bacterial colony count at least threefold higher in the sample from central line as compared to that obtained from peripheral line, or same organism recovered from percutaneous blood culture and from quantitative culture of catheter, which should be at least more than 15 colony forming units, a shorter time to positive culture in a central line sample than the peripheral sample, that is differential time to positivity, at least 2 hours earlier in the central line sample. The second is the CLABSI. CLABSI is a surveillance definition used by the CDC and defined as recovery of a pathogen from a blood culture in a patient who had central line at the time of infection or within 48 hours before development of infection. The infection cannot be related to any other infection the patient might have and must not have been present or incubating when the patient was admitted to the facility. Coming to the pathophysiology, the catheters can be tunneled or non-tunneled. Tunneled catheters are generally used for long-term purposes. They are inserted by forming a subcutaneous tract, which is not seen in short-term or non-tunneled catheters. Bacteria can migrate into the bloodstream from the skin either extraluminally or intraluminally. Extraluminal transmission of bacteria is more common in non-tunneled catheters. The fibrous tissue which is formed around the catheters prevent this extraluminal transmission in tunneled catheters. If the catheter is placed for more than 7 to 10 days, intraluminal transmission is high. This is basically due to hub contamination. Other factors like host factors, which includes chronic illnesses, immunocompromised states, malnutrition, use of total parental nutrition, extremes of ages, poor skin integrity, and prolonged hospitalizations can also increase the risk of CLABSI. If the lines are inserted in an emergency situation than an elective procedure, the risk of infections are higher. If you have a full barrier precautions while insertion, the risk of infections are less. Of course, the skill of the operator and a proper catheter care will diminish or reduce the risk of infections. Coming to the site of insertion, the lines inserted in the femoral area carry a higher risk of infection than the subclavian line. Coming to the management and treatment of CLABSI. When CLABSI is suspected, empirical antibiotic therapy should be based on the most likely organism, local prevalence, and antimicrobial susceptibility patterns in that institution, host factors, and overall clinical picture like patient is stable, unstable, medical or surgical patient, perioperative patient, post trauma patient, organ dysfunction, all this clinical picture has to be taken into account. So, while awaiting cultures, empirical treatment should be instituted promptly. In general, coverage for common gram positive and gram negative organisms are necessary. Overall clinical picture, like whether the patient is in medical ICU or surgical ICU, whether the patient is a post operative patient, post transplant patient, depending on number of organ dysfunction, possible source of infection, we have to decide the possible antibiotic. The most common antibiotics for gram positive coverage are glycopeptides, that is teicoplanin and vancomycin being the commonest. For gram negative cover, commonly used are third generation cephalosporins, beta-lactam, beta-lactamase inhibitors, carbapenems, and polymyxins. Among the antifungals, azoles and echinocandins are the most commonly used. Going further in the management of CLABSI, all non-tunneled catheters causing CLABSI should be removed promptly, sometimes even before it is proven when clinical suspicion is high. Once antimicrobial susceptibility results are available, de-escalation to specific and appropriate therapy is recommended. If blood cultures have no growth, the need for further empirical antibiotic treatment should be reassessed. If unexplained fever or sepsis persists in a patient with short-term central venous or arterial catheter, and paired peripheral venipuncture and catheter blood culture have failed to identify CLABSI, the catheter should be removed. In the case of tunneled hemodialysis catheters, uncomplicated exit site infections can be treated with short course topical or systemic antimicrobials. All tunnel infections will require catheter removal due to high risk of CLABSI. Additional indications for removal in CLABSI from hemodialysis access include persistent symptoms beyond 36 hours or severe sepsis, hemodynamic instability, and metastatic infection. Blood cultures that remain positive more than 72 hours of appropriate antimicrobial therapy. Difficult to clear organisms like Staphylococcus aureus, Pseudomonas, or fungi. Recurrence of uncomplicated CLABSI. In case of non-virulent organism, when salvaged for difficult access. Salvage therapy can be an important aspect of management of CLABSI. Salvage therapy is nothing but it's a combination of systemic therapy coupled with antimicrobial lock. Antimicrobial lock includes heparin and a high concentration of antimicrobial agent that is selected based on the susceptibility pattern. So, salvage therapy can be attempted in limited instances such as uncomplicated CLABSI caused by organisms other than Staphylococcus aureus, Pseudomonas aeruginosa, Bacillus species, Micrococcus species, Propionibacteria, fungi, or Mycobacterium. And the patients with limited vascular access sites or the one who are solely dependent on central access for survival. Coming to the duration of therapy. For patients with uncomplicated CRBSI like no endocarditis or metastatic infection, in absence of risk factors for hematogenous spread like hardware, it means prosthetics or immunosuppression, and a negative blood culture, 72 hours of catheter removal, following approach of antimicrobial therapy is recommended. In case of Staphylococcus aureus, 14 days in the absence of endocarditis. Coagulase negative staphylococci for 7 days. In case of enterococci and gram negative bacteria, duration of 10 to 14 days. For candidal infection, 14 days in the absence of retinitis or after getting a negative blood cultures. Management of CLABSI at times can be challenging because of emergence of multi-drug resistant bacteria these days. So CLABSI can be potentially prevented by maintaining certain strict precautions during insertion and during maintenance of these lines. During insertion, proper hand hygiene by washing hands with soap and water or with alcohol based gels or foams. Gloves do not obviate the need for hand hygiene. Strict aseptic techniques by using maximum sterile barrier precautions, including a full body drape when inserting central venous catheters. Use of 2% chlorhexidine in skin preparations for disinfecting or clearing skin before insertion. Ultrasound guidance by an experienced provider for placement to circumvent mechanical complications and reduce the number of attempts. Avoid the femoral line as the choice of central line placement due to increased risk of infection, and prefer the subclavian vein when possible for non-tunnel catheters. Promptly remove any central line which is no longer required. Replace central lines placed during an emergency as soon as possible or at least within 48 hours because the full barrier precautions are not followed. And use a checklist. So checklist will help us to adhere all the protocols which are necessary during the insertion techniques to prevent CLAPSy. This image shows use of ultrasound during insertion of lines and a full barrier precautions which has to be followed while inserting central lines. During maintenance, CLAPSy can be prevented by following these protocol, that is disinfectant the catheter hubs, injection ports and connections before accessing the line. Replace administration sets other than sets used for lipids or blood products every 96 hours. And assess the need for central line daily. Whenever it is not needed, promptly remove it. So these were the various aspects of central line associated bloodstream infections. Let us adhere to antibiotic stewardship practices, use the antibiotics wisely, and prevent the emergence of multi-drug resistant organisms. Thank you.